In our practice, we see people with thoracic pain, and we kind of divide them into two categories, if you would agree. People that have pretty good normal alignment, and then people that might have like a crazy thoracic curve, right? Commonly called scoliosis. And really kind of differentiating the patients into each group helps us to treat them better, right?
Yep.
Thoracic instability can look or be composed of kind of several different things. Scoliosis, which we're going to talk more about, snapping scapula, disc herniations, bone marrow edema, slipping rib, radiculopathy. People can actually get pinched nerves in their thoracic spine that might radiate towards the front of their chest. Subluxations. Really, the list is pretty inclusive of a lot of things that contribute to thoracic instability.
I would say, Danielle, too, this is probably one of the most underdiagnosed conditions.
I believe that, yeah.
Anybody who goes on Google and you type in thoracic instability, there's almost nothing. Like in the medical literature, you know, we see a lot of upper cervical instability and other instabilities, or lumbar instability. There's lots and lots of medical literature. And then, when's the last time you saw somebody get a fusion surgery of the thoracic spine? It's almost never.
Yeah.
It's almost never. So I think this is like a hidden diagnosis, and people at home too would know that they have instability because they click, crack, grind. So the world record of most amount of manipulations by one person was a patient that I saw many years ago. Well, you actually saw the patient too, where the patient figured out that he had self-manipulated himself 677,000 times.
Holy cow.
Because when you start clicking, and it's almost always like right here where people adjust. That's probably number one, and number two is going to be the neck. And the problem is, each time you manipulate it, you're getting the ligaments looser. Much like a screw on a hinge. Every time you use the door, you're actually making it looser. So even somebody as loosey-goosey as that, can still get stabilization with prolotherapy.
I think, too, to make the point about it being underdiagnosed, is there's a lack of motion imaging in this area, right?
True.
It kind of in the medical world. And then even like slipping rib, I see a lot of slipping rib cases, and that's one, too, where people that have ribs that slip in and out, I mean, you can get an X-ray, you can get an MRI, and it's really not going to, unless that rib is maybe completely dislocated, it's really not going to pick up on anything like that. And it may be that the day you got your MRI, your rib was in place. But 2 hours after you left the MRI facility, it slips out. So very tricky. Somebody,
obviously people come in with their scans. So there's indirect indicators that you have instability. Like one indirect indicator would be that you have, the discs are degenerated. Like why is the discs at T4, 5 degenerated, but T2, T3 isn't? Well, you had instability at T4, 5, and the increased pressure caused the disc to degenerate, or it caused the bone marrow in the vertebrae to get inflamed or edema. So whenever you see these things in areas where you have pain, it's likely this is the cause of the problem, and the treatment of that is, of course, proper posture, but also you have to get the ligaments strong, and you do that by prolotherapy.
Absolutely. People ask me a lot, how do you get instability in the thoracic spine? What happens? Well, yeah, you could get hit by a car or, fall off your bike or whatever. Or you could sit in a really crummy posture like this for 10 hours a day, 5 days a week, and then go home and look at another screen with bad posture. And that will slowly stretch out all of those ligaments until those joints become unstable. Historically, I would have sat like that, where you're just like on a computer and you're hunched over, but then like your neck is up, not great.
And that's kind of where people feel the pain.
Yeah. I would say a majority of people in our practice that we see, it's like this base of the neck is really, really painful. Like a lot of people have pain there.
Yeah, and then when somebody has slipping rib, often it's like they'll either have the pain over here or they'll have the pain over here, versus like when you have pain in the middle, it's probably going to be the vertebral or cervical instability or thoracic instability.
That's a good point, too, with thoracic instability, is most often people either have it like in the facet joints along the actual vertebral column, or they have it where it connects to the rib with a slipping rib. Usually people are kind of one of the two.
When you do prolotherapy, where actually are you doing prolotherapy?
Well, so for people that have more so on the vertebral column, we would do it at the facet joints where each vertebrae connects to the one above it. And then if it is more of a slipping rib, you can see where the vertebrae connects to the ribs. That would be more of the target there. In the beginning of this video, we talked about people with thoracic pain that are in normal alignment or people that have what we call body destructure or their curve has kind of gone, what do you say, catawampus?
Yeah, catawampus.
Catawampus, yeah.
Cockamamie.
Cockamamie, that's what it is.
Like, look at this. When you think this is cockamamie.
Yeah, the new medical term.
Isn't it kind of weird? We made this years ago. Then recently we got this, and it's almost like the.
Oh, that is funny.
It's like almost the exact same.
So scoliosis here, obviously you can see this abnormal curve here. When one part of the curve starts to kind of morph or become dysfunctional, it will definitely affect the rest of the curve, right? Maybe not right away, but over time. And so people that have issues with their curve here, it can kind of trickle down. Like people with scoliosis in their thoracic spine could have low back pain too, right? For sure. You know, just the way that it's transmitting abnormal forces.
So say your atlas is out, the C1, okay. So it's out, let's say to the left. Then what you'll do is you have to move then your body. You know, you have to move your body. So that's, you know, so an upper cervical chiropractor would say that this whole thing can be from just upper cervical instability. Now, you and I, we often see people who have chronic pain. So if somebody had this, we would normally see they have pain here because the maximum ligament forces are going to be here and here at the apexes of the curve. So we can help the pain, but the actual scoliosis, you have to get at the root cause of the scoliosis, which often is muscular imbalance, or if there is an atlas issue, you have to deal with that.
So when people come to our office with scoliosis, you know, we're not going to correct it with prolotherapy, but there definitely are resources that people can use to work on at least reducing the scoliosis to get themselves in a better alignment, like the Clear Institute. They do a really great job of that, and then we will definitely help with the pain. Or, you know, it's not that somebody couldn't also have instability here too, that we can work on tightening those ligaments, and then if they do get at the root cause, which we're always about with the scoliosis, then usually they do very well.
Yeah, in Florida here we refer to the Clear Scoliosis Centers, but they have centers all over the country. But there are other scoliosis centers because what they'll normally do is they'll figure out where the muscular imbalances are. I'll give you an example. Like somebody might wear a weight where the weight is on this side, you know, so, and, you know, like you might put a weight on this side just to balance out the pelvis. So that's a specialty in and of itself. But again, it works good that we can get rid of the pain, but the actual muscular imbalances, we have to send them out to somebody who's a specialist in that. There's so many different curves. This, I would say this is probably the hunched over thing is the normal thing we see.
Right. It's not normal, but it's the most common thing that probably the most common kind of curve walking around.
Hyperkyphosis is what we call it. If I was walking around like this, you'd say, Doc, you're going to get low back pain. You know, wherever the maximum force is on the tissue. So anybody who's there, if you have a scoliosis curve and you have pain at the apex of the curve, that's probably ligamentous.
That curve that we were talking about with that exaggerated kyphosis, this is what it looks like on MRI. So like the cervical curve is more straight, you have an exaggerated kyphosis here, and then you're losing that lordotic curve. So just to kind of make the point again, where when you have changes in your curve in one area, it will slowly affect all the rest of it. This can happen in any age group. You know, this can happen in kids, this can happen in adults or older adults. And so instead of standing like this, you know, kind of hunched over, or even the opposite, you don't want to be what they call like a sway back either, but just trying to stand in better alignment. And sometimes, you know, when we're seeing people with thoracic, I shouldn't even say sometimes, I would say majority of the time when I treat somebody for a thoracic instability, we do use bracing as part of our treatment plan to just hold everything together while it's healing. It's not forever, it's a temporary thing just to help the medical procedure, prolotherapy, be the most successful.
I hear a lot from parents, because, you know, we see the parents, then they have these kids who are 8 years old, 7 years old, 10 years old, and they know that if their child doesn't have good posture, thoracic pain and thoracic instability, it's just going to happen in them in a much younger age. So, and they're, you know, it's just hard with the cell phone. You know, like the kids are just, like the adults, we're all addicted to the cell phone.
When we talk about, you know, muscle strengthening for thoracic, muscular imbalances or scoliosis, all of these little dots, I mean, these are all muscle attachments here. That's a lot of muscles that surround the thoracic spine. And you even have all like these really, really long muscles that travel through your whole spine. So there's a lot of big powerhouse stabilizers, muscles, what I'm talking about, that support that thoracic spine. So if somebody has an instability, we do prolotherapy and we get it to be strong and stable again. Building these muscles around that area will just further help to strengthen that stability and never have to treat it again, like at best case scenario. So by keeping these muscles strong, that really helps.
It's common that, you know, you'll hear or I'll hear that the person goes to a physical therapist and they'll say like a certain muscle is under tension all the time. Like they always have to get a massage there or dry needling or... So imagine if somebody had this muscle right here, was always under tension. What I like about this is it shows that this could affect the sacrum all the way up to the skull. Because somebody could have an instability right here.
Yeah.
Or they have an instability, let's say at T5, so they have T5 instability. Well, basically what it means is that their body's going to recruit a bunch of muscles to try to stabilize it. So it could recruit muscles like up here, it could recruit muscles up here. So if somebody had a chronic spinal symptom that they went to a lot of people for and nobody could figure it out, one of the things to consider is that you have some kind of spinal instability, and the thoracic instabilities are the ones that can really affect all the other parts of the spine. And like I said at the beginning, I think it's the most underdiagnosed probably instability condition because nobody thinks about it because the ribs, they got discs here, they got ribs, and you know the ribs really stabilize it. And the reason why we have ribs is because you got to protect the lungs and the heart, because you know, like imagine kids, they're punching each other, and if you didn't have the ribs, you know, like that's the purpose of the ribs. So it is true that this is the most stable part of the spine. Like this is the most stable part because of the ribs. But I think medicine then, because there's the ribs to stabilize it, they don't think about instability. So anybody, you know, they move and they can feel a cracking, clicking, grinding, or they, you know, there's just a clicking, popping, and you have a chronic pain, it's likely instability. And then the treatment of that, of course, is prolotherapy.
I've had people, like other professionals, tell me like, oh, the thoracolumbar area, so that's the lower thoracic, it doesn't move. Like, well, it does, and it actually can move too much. But, you know, but I think that that's like a common, I've heard that about the SI joint too, like, oh, the SI doesn't move. Well, we see the opposite, you know, when it moves too much. So I think that that is kind of an area that maybe isn't always as examined as it should be. This is actually a video of me treating somebody for slipping ribs. So here's the ultrasound. Here's the rib right here. Okay, there's the top of the rib. And then this is the thoracic vertebrae that's coming out and that attaches to the rib. So we're doing it under ultrasound guidance. You're going to see my needle coming in through here. And injecting solution there. And then we move down to the next level right through here. And people too like can get slipping rib at any rib, right? You know, it's equal opportunity. You could have one rib, you could have several ribs that all
it's pretty routine. It's pretty routine when you treat somebody though. You're treating the facet joints and you're treating the ribs, like, because you know it's really a mesh. You know, we talk about it as separate, but you need all the ligamentous support you can there once you have instability. So if anything, we call it comprehensive prolotherapy because we're just, like if you had 4 screws on a hinge and one screw was mainly loose, you would absolutely take the screwdriver and do all 4 screws because you don't want to have the whole thing reliant on one tight screw.
Right. I'm just going to go back for a second to this picture here. I've had cases where people come in and they're like, okay, this pain is radiating down my whole side, but this kind of seems to be maybe the hub of it, or I find a hub of it on exam. Sometimes I'll do diagnostic blocks too, where I'll say, I'm just going to take a numbing just to start. We'll use ultrasound. I'm going to inject it into this facet joint or where this rib attaches, and let's just kind of see, like, does your pain... It's not going to necessarily get rid of all the pain immediately unless that was the only structure, but does it get rid of it 50%? Or does it get rid of a big chunk of it? Because that helps us too to determine, yes, it's this T5 area that really is the weakest link. We're going to strengthen everything else around it, but now we know.